Okay, so this is also one of the e-lectures in the heart series, and this is approximately around 25 slides, and this will give you synopsis of infective cardiac diseases and AAA. And I said cardiac tamponade because cardiac tamponade is one of the medical emergency of one of the kind of cardiac diseases, infective cardiac diseases. So I'll discuss that also in this presentation. Let's go to the next slide. What is an infective cardiac disease? Uh, the It's a it's an infection, and there is an infection of the lining of the heart. So it's an infectious disease process of the endocardium or lining of the heart. Old term which was used for this was bacterial endocarditis. It includes infective endocarditis and pericarditis. Infective endocarditis, it is an infection of the endocardium, heart valves, or cardiac prosthesis. prosthesis. Um, Causes of infective endocarditis, it's infection. So there is bacteria, and whenever in your body there is bacteria, the bacteria likes to attack two organs, the kidneys and the heart. So when they attack the heart, they will attack the valves. And once the microorganisms they begin to proliferate or multiply on the valve, they will form what is called vegetation, or it's a purulent stuff like a pussy stuff attached to the heart valve. And fungi on top of it can multiply on heart valves just like bacteria. So, and the it can be streptococci, staphylococci, or fungal infections. So as I said, bacteria likes to attack two organs, the kidneys and heart. When they attack the heart, they like to attack the valves. And once the microorganisms begins to multiply on the valve, they can form what is called vegetation or purulent stuff which is attached to the heart valve. Fungi can multiply on heart valves just like bacteria. Now, if there is a prosthetic valves in the heart, then the bacteria can easily stick to the this foreign device because it's a foreign, but something foreign which is kept inside the heart. So bacteria can easily stick to it. Long-term indwelling catheters. So clients with catheters, central lines, Foley's. That's why in the hospital setting, nurses are taught many times about the catheter-related infections. So when it eventually happens, when there is infection due to uh, catheters, indwelling catheters like central lines and Foley's, which remain in place for extended time periods, then the patient has a risk of developing an infection. And this infection can lead to an infection in the heart valve. Is If there has been a recent cardiac surgery, then there can be a contamination of the area where the surgery was. So that can also lead to the infective endocarditis. There is something called rheumatic heart disease, systemic lupus erythematosus. Now, these are uh, these diseases. They will do the calcification of the heart valve, and they will make the heart valve more stiff. There is congenital heart defects like valvular dysfunction that can also lead to infective endocarditis because malformed heart valves are more susceptible to bacterial colonization. Uh, Also, IV drug abusers who do not follow the aseptic techniques, and they can inject bacteria into their blood. Injection of bacteria into a vein, it follows the normal blood flow path and it will return to the right side of the heart. The first valve for the bacteria to attack would be the tricuspid valve. This is why most of the IV drug abusers, they develop tricuspid valve problems. So these are some of the causes of infective endocarditis. So anything which is happening around heart, or any foreign body or any infection or IV drug abuse, or some diseases. So they are all are responsible for endocarditis infection, endocardium infection. Signs and symptoms of infective endocarditis: fever, and it's expected because it's normal response to infection. Uh, and some bacteria and fungi, they cannot survive in an environment with an elevated temperature. So splenomegaly. The spleen is an important immune system organ, and the spleen is a very important organ which is working overtime to protect immunity. So splenomegaly will lead to hypertrophy and of the heart, and that's how you can see as one of the signs of infective endocarditis. Petechiae, petechiae. These are, you have heard it a lot in the other presentations regarding skin or other body systems. So tiny spots, which are petechia, is nothing, it's just the tiny spots which are caused by hemorrhaging under the skin. Hematuria, the now the microemboli, or the any kind of septic emboli which is caused by this disease can uh, affect any organ, so leading to you know bleeding. So you can see hematuria. You can also have some cardiac murmurs. Now, if there is a vegetation on the valve, it will prevent the valve from closing properly, and this will result in a murmur. Also, the any microemboli or septic emboli can also affect the other, or one of the important organs of the body, the lungs. And so when it infects the lungs due to our immune system response or the inflammatory response, we feel some pleuritic pain, fatigue, and weakness. Yes, because eventually the heart is moving towards heart failure. So this the patient will experience a lot of weakness. Uh, Now, if there is a clot formation on the mitral or aortic valves, it can lead to left-sided heart failure, and it will be a late sign. I mean, you don't see the signs of left-sided heart failure in the beginning. It will be late sign. So you will see all that nocturnal dyspneas, the heart sound S3, pink frothy sputum, cough, crackles, orthopnea, tachycardia, restlessness, JVD, hepatomegaly, ascites, peripheral edema, and pulmonary edema. So these are the signs and symptoms of infective endocarditis. Tests. Uh, Anytime, even when you become nurses, anytime you suspect any um, fever or there is fever out of range, the first thing the doctor will ask you to do is blood cultures. So because they want to know what is the infecting microorganism in the body which is leading to this infection. WC will be definitely elevated. If you do CBC and anemia panel, it will show some positive signs of anemia in infective endocarditis. The ESR will be elevated, creatinine will be elevated, urine will show some proteinuria and hematuria. Echocardiography can show the valvular damage, and electrocardiogram can show the rhythm atrial fibrillation. So this is how you can do some test to assess the person who's having infective endocarditis. Treatments. This is given for antibiotics infection, so we need to give some antibiotics, and antibiotics are given for 2 to 6 weeks, and they are given in high doses. The other treatment which we can do is, another option is, we can do surgery and we can repair or replace the damaged valve. Like, not we can, but the doctor can repair or replace the damaged valve. Um, in infective endocarditis, things which a nurse should be getting worried about, or the healthcare professionals should be getting worried about, is taking care of this patient. The stroke or any emboli might be traveling to the other organs, any the disease leading to heart failure, any infection, or any erosion of the heart muscle, or any valve stenosis. So let's go to the, and then how nurse can help. So what is my role in, if I have a patient with infective endocarditis? I want to manage the IV therapy, and I will observe for any signs of infection. Uh, we will, I think this should have been separate. Manage IV therapy and then observe for any signs of infection. Then provide periods of rest and exercise in moderation to prevent any venous stasis. Because we're not we are preventing any thrombus or any clot formation. We will use anti-embolism stockings to prevent thrombus formation. We will teach client or the patient about antibiotics therapy for 6 weeks, and then there'll be and before any invasive procedures in routine dental care, if the patient has infective endocarditis, there is a great need for prophylactic antibiotics. Uh, I think, as a rule, if you go for the dental procedure, they do give you, if it's like a more invasive, they do give you antibiotics. But with infective endocarditis patients, it's very important they should be educated that if you're going for any routine dental care or any procedure, invasive procedure at the dentist office, you need to have the prophylactic antibiotics. Regarding um, oral care, because infectious organisms can enter bloodstream through gums, with vigorous brushing or oral treatments, we have to tell them that do your brushing very gently. We don't want any infectious organism to enter the bloodstream. So uh, to prevent further damage, these are the few teachings or things to keep in mind if nurses are taking care of patient with infective endocarditis. The another kind of infectious cardiac disease is pericarditis, and we will learn about this in two forms. It can be called acute pericarditis and chronic pericarditis. Acute pericarditis is the inflammation of the sac surrounding the heart, and it can have a lot of causes. The most common cause can be the viral infection, any trauma, any uremia, any connective tissue or endocrine system diseases. I said diseases, the spelling is wrong, so it's diseases. Okay, endocrine system diseases, and then any post myositis or any neoplasms. So all these can cause uh, uh, acute pericarditis, which is inflammation of the sac surrounding the heart. Chronic pericarditis, it leads to fibrous thickening of the pericardium, and which results in constrictive movement of heart muscle, and there is a restrictive diastolic filling in the heart. So this is what is the acute and chronic pericarditis definition and their causes. Signs and symptoms of acute and chronic pericarditis. Common signs or symptoms or the data which uh, we can collect, subjective, objective, whatever it is, whatever we can collect from the patient who's having acute pericarditis is substernal pain, which can radiate to neck and which can get worse by breathing. Patient can show signs of coughing. There can be a heart sound, which is known as friction rub heart sound, which is like scratchy heart sound, high WBC, fever, malaise. An ECG can show your ST and T wave elevations, followed by inverted T wave when ST comes back to its baseline. Uh, Now, common signs and symptoms of chronic pericarditis are increasing shortness of breath and fatigue, leading to progressive heart failure. So let's go to the next slide. Now, how can you manage pericarditis? The most important thing to remember when you have pericarditis is the patient needs to have bed rest as long as fever and pain persist, which will reduce his metabolic needs. So he doesn't have to, um, you know, uh, he doesn't have to make his heart work harder. We can give this patient pain NSAIDs to relieve pain and reduce inflammation. We can give them steroids if the NSAIDs have not been effective. But for giving steroids, uh, we want to be sure that there are no uh, infection. Uh, Antibacterial, antifungal, or antiviral therapy can be done on this patient. And then um, I don't know why I wrote if infectious cause. I think I was typing something else. Let's go back. So we can give them NSAIDs to relieve pain and reduce inflammation. We can give them steroids. If NSAIDs are ineffective, we can also use the antibacterial, antifungal, and antiviral therapy. Just ignore if infectious cause, just ignore that word. And then we can also do the pericardiocentesis, and it's just like you remove the excess fluid from the pericardial sac or space. And then we can do partial pericardiectomy, which creates the window which allows the fluid to drain into pleural space, and this is mostly done in chronic pericarditis. And then there is total pericardiectomy, which allows the adequate filling and contraction of the heart. So this is how the therapeutic management of pericarditis can be done. And out of this, pericardiocentesis and pericardiectomy, total pericardiectomy, all these are done by the doctors. Nurses, they're supposed to know about the pain, how they can help to reduce the pain, any antibiotics, and also telling the patient to pace their activity, bed rest. They have to be on bed rest as long as fever and pain persist. So if they have this condition, they cannot be mowing the lawn. Okay, let's go to the next slide. These are the things which are very dangerous for the patients who are suffering from pericarditis. Infection. So any untreated infection can be fatal. Then there can be some effusions from pericardial area. And the most dangerous and the most common which can happen on these, the most fatal indicator which can happen on these pericarditis is cardiac tamponade. And it is a medical emergency where there is excess fluid has collected in the pericardial sac that interferes with heart filling and normal heart function. Um, what are the complications when patient has this cardiac tamponade complication? The the common sign and symptoms of cardiac tamponade complications are JVD, drop in BP, muffled heart sounds, pulses, paradoxes, LOC change, increasing heart rate, and edema. Now, why they have JVD? Heart is squeezed, so blood cannot fill heart. Heart is getting squeezed, so the blood cannot fill heart. Instead, the blood backs up into venous system, and when the blood backs up into the venous system, it causes distension of jugular vein. That's why we have JVD. Why there is drop in blood pressure? When the heart squeezes, the cardiac output it drops, and there is a decreased forward flow of volume. And if there is less volume, there is less pressure, as we know. So there is drop in blood pressure. So why there is drop in blood pressure? Because when the heart squeezes, the cardiac output drops and there is a decreased forward flow of blood volume. And if there is less volume, there is less pressure. Muffled heart sounds. And muffled heart sounds are due to the fluid accumulation around the heart. So there is fluid accumulates around the heart, so it leads to muffled heart sounds. What is pulses paradoxes? When there is a blood pressure drop more than 10 millimeters of mercury with inspiration, then it is known as pulses paradox. And why it happens with cardiac tamponade? Because with inspiration there is more pressure squeezing down on the heart. So that's why in pulses paradoxes there is more drop of more than 10 millimeters of mercury with inspiration. LOC change, cardiac output drops, so there is less perfusion in the brain, so there is LOC change. Increasing heart rate, because it's trying to compensate for the drop in cardiac output. Whenever there is drop in cardiac output, we will have high heart rate. Edema, because the blood is backing up into the venous system. So that's why these are the signs and symptoms of this complication, the cardiac tamponade. Now, yes, I just touched cardiac tamponade a little bit here. I just gave you the definition. No, I told you that this is dangerous for patients suffering from pericarditis, and if the patient exhibits cardiac tamponade, it is a medical emergency, and I defined the cardiac tamponade. And I want you to know what are the signs of this complication. So I just want you to know this much about the cardiac tamponade. Let's go to let's go to abdominal aortic aneurysm. Again, S is missing from it. So it's ANEURYSM. Now we talked about atherosclerosis, arteriosclerosis. It's all connected. How you'll see it's all connected. Now what is aortic aneurysm? It is a localized dilation or outpouching of weakened area in aorta, which is classified by regions such as thoracic or abdominal or cerebral. So for the purpose of this presentation, as we are in heart, we will be here only doing for abdominal. We will not be dealing with thoracic aneurysm, aortic aneurysm, or cerebral. Our concentration here is on abdominal. Most common is abdominal aortic aneurysm, or AAA. Okay. Now I pulled this from from Google, this diagram, and it shows you both the thoracic aneurysm and also the abdominal aneurysm, and you can see how there is outpouching or the bulge in the wall of the aorta. An aortic abdominal aneurysm or bulge in the wall of the aorta is located in the part of the aorta that passes through the abdomen. And large aneurysms, they tend to rupture. And when they tend to rupture, it's a life-threatening emergency. Major risk factor of AAA is atherosclerosis. So you see it's all connected. Now, causes and sign and symptoms of AAA. Causes. The number one cause of AAA is atherosclerosis. Atherosclerosis will weaken the aorta. So that's why we have outpouching on the aortic wall. Hypertension, every ventricular contraction causes a shearing or pulsatile force on the walls of the aorta. So continued exposure of the weakened area to the shearing force increases the blood pressure. So every ventricular contraction, it is causing a pulsatile force on the walls of the aorta, and continued exposure of the weakened area to this force, it makes the blood pressure go up. There is something called Marfan syndrome, and it is genetic. It's genetic connective tissue disease which causes weakening of the aortic valve. So don't get disturbed by this big word Marfan syndrome. It's just a genetic connective tissue disease which weakens the walls of the aorta. Um, so then you have blunt trauma. Blunt trauma, it weakens. Blunt trauma, infections, they all weaken the aortic wall. Thrombus, blood flow inside the aneurysm is slow, and the calcium deposits can happen in the wall of the aorta. So thrombus formation can also lead to AAA. Sign and symptoms of AAA. There are so many signs and symptoms I have typed here. The one thing which is very different, or which is very significant to this, is that there is a pulsatile mass in periumbilical area, and it is due to enlargement of the aorta, and you can see um, you can feel that pulsatile mass. You hear a systolic bruit over the aorta, and we all know bruit is a turbulent blood flow. Change in LOC, widening, or arteries, they are becoming more wide. It occurs at the site where the aneurysm is developing or where the aneurysm occurs. And the blood slows within the widened area of the aorta. And the area which is distal, in this case the brain, it receives less flow. Less perfusion to the head results in decreased LOC. So that's why there is changes in LOC. So the artery, it becomes wide, and it becomes wide at the site where this aneurysm is. So blood slows within the widened area of the aorta. So there has to be a certain size and diameter of the aorta, and if it becomes more wide, the blood inside that aorta, it becomes slow. The flow becomes slow, and so the area which is distal to the aorta, which is our brain, it receives less blood flow. So that's why there is less perfusion to the head, and this results in low LOC. Now, weakness, sweating, tachycardia, and hypertension, they are all happening because of hemorrhage. So they can all happen if there is a hemorrhage inside. There is a lumbar pain, back pain, which radiates to your flank and groin, and there is also a severe, persistent abdominal and back pain. And this is all happening because there is a pressure on lumbar nerves. What you must know about this AAA is that it may be asymptomatic, and it may be discovered by chance in routine physical. Pain is usually a late clue. Patient may report heartbeat in his abdomen. There is a possible pulsating abdominal mass, and you do not palpate as there is a risk of rupturing this mass. The patients will have cool or cyanotic extremities, and you with auscultation you will hear bruit. So this is the most important thing which I want you to know. Test and treatments. Test, yes, we will can do the X-ray to see the picture. We can have ultrasonography. We can have CT abdomen, and we can have MRI. How can we treat this? We can treat this by, we want to modify some risk factors which are increasing the cholesterol. So we'll modify the risk factors to decrease cholesterol and blood pressure so that there is not much expansion of this aortic wall, and which can lead to rupture of the aneurysm which is on the aortic wall. We will take help of beta blockers to reduce risk of aneurysm expansion and rupture, and as well as to decrease blood pressure. There is something called Dacron graft which repairs aneurysm. So resection of aneurysm and replacement of damaged aortic section can be done with this graft. We can monitor for signs of acute blood loss, which can be decreasing blood pressure, increasing pulse and respiratory rate, cool clammy skin, restlessness, and decreased sensation. We can do emergency surgery if there has been a rupture or threatened rupture. I don't know why there are just some empty slides. So this, though it extended up to 25 slides, but I only typed till 21 slides. So this brings to the end of 3 topics: infective cardiac diseases, and under which you have infective endocarditis, pericarditis, and then one of the medical emergency of pericarditis was cardiac tamponade, and then in the end I explained to you about AAA. Okay, so thank you.